Hello friends and welcome to my YouTube channel. In this video we will cover ventilator associated pneumonia. So without any delay, let's get started. Ventilator associated pneumonia. It occurs 48 to 72 hours after ET tube intubation. It is characterized by clinical signs like pyrexia, raised WBC count, purulent bronchial secretions, by microbiological evidence of positive sputum culture, and by radiological signs in chest X-ray which show new or progressive pulmonary infiltrates. Pathogens associated with VAP. It is mainly caused by gram-negative organisms, but gram-positive bacteria such as MRSA are not uncommon. Typically, bacteria causing early onset VAP include Streptococcus pneumoniae, Haemophilus influenza, methicillin-sensitive Staphylococcus aureus, gram-negative bacilli, E. coli, Klebsiella pneumoniae, Enterobacter and Proteus species, and Serratia marcescens. Culprits of late VAP are drug-resistant organisms such as MRSA, Acinetobacter, Pseudomonas aeruginosa, and extended spectrum beta-lactamase producing bacteria. Pathogenesis of VAP. It is thought to be caused by entry of infective secretions into distal bronchi. Patients are usually immunosuppressed and their oropharynx becomes colonized with organisms, especially gram-negative bacteria. Oral and nasal tubes can cause trauma, leading to infections such as sinusitis. The natural protection like cough reflex, tracheobronchial secretions, mucociliary linings, saliva, and nasal mucosa are less effective in these patients. The pathogens enter the lower lung through mechanical routes such as around the tracheal tube cuff, suction catheter, and ventilation tubings. Factors that increase the risk of development of VAP. Patient factors include advanced age, low serum albumin, ARDS, COPD, other lung diseases, trauma and burns, multiple organ failure, large volume gastric aspirates, and upper respiratory tract colonization. Interventional factors include prolonged ventilation, level of sedation which is too high, use of neuromuscular blocking drugs, use of antacids such as PPIs and S2 blockers, NG tube, supine position, frequent circuit changes, and transfer outside ICU. Measures to reduce the risk of development of VAP include general measures. General measures which include use of sterile equipment, regular hand washing, using barrier nursing such as gloves and apron, and minimal contact with patient reduce the incidence of VAP in ICU. Specific measures which reduce the load of pathogens and their entry into the lower respiratory tract include number 1, reducing oral colonization. This can be done by using antiseptic mouthwash, example chlorhexidine, use of silver-coated ET tubes, and selective decontamination of digestive tract using non-absorbable antimicrobials such as polymyxin E and amphotericin B. Reducing aspiration. Patients should be nursed in 30 to 45 degree head-up position. ET tubes with subglottic secretion drainage port with regular subglottic section should be used. Regular monitoring every 4 hours and maintenance of ET tube cuff pressure should be done. Minimizing the duration of mechanical ventilation. This is achieved by an early tracheostomy. Tracheostomies have proven to lower the incidence of VAP. Periodic sedative interruptions and daily assessment of readiness to extubate the patient may reduce the duration of mechanical ventilation. Stress ulcer prophylaxis. Reducing the acidity of stomach in stress ulcer prophylaxis is claimed to increase the incidence of VAP by increasing the proliferation of gram-negative bacteria. Use of H2 blockers or sucralfate instead of PPIs. Use of H2 blockers or sucralfate instead of PPIs are suggested to reduce the risk of VAP. Enteral feeding can increase the risk of VAP by altering the gastric acidity and increasing the risk of aspiration. But benefits of enteral feeding usually outweigh this small risk. This is a table which shows the diagnostic criteria for VAP. First is the Johnson criteria. Presence of any new or progressive radiographic infiltrate plus at least 2 of the 3 clinical features, that is temperature more than 38 degrees Celsius, WBC count more than 12,000 or less than 4,000, or presence of purulent tracheal secretions suggests ventilator associated pneumonia. Second score is CPIS, clinical pulmonary infection score. A score of 6 or more suggests VAP, and these are the criteria that are used: temperature, leukocyte count, tracheal secretions, radiographic findings, culture results, and PF ratio. The third is the CDC criteria, which you can read on your screens. This is all about ventilator associated pneumonia. Hope this was helpful for you. If you liked the video, please subscribe to our channel and share the video. Thank you.